everyone, thanks for joining. We're going to get started now. Just a reminder, we have 30 minutes, one question, one follow-up, and today we have Dr. Yaffe and Dr. Allen here today, so I'll turn it over to them for some brief remarks.
Thanks very much, and good afternoon, everyone. I'm pleased to be joined today by Dr. Vanessa Allen, the Chief of Microbiology and Laboratory Science at Public Health Ontario. And Dr. Allen will be providing an update on Public Health Ontario's changes to variant of concern laboratory testing. But first, today being Thursday, I am going to provide an overview of the trends and numbers that we have seen since the last update, as well as looking ahead to the weekend and beyond. Since the last update on Monday, Ontario has reported an additional 5,497 cases of COVID-19. That's 1,546 cases on Tuesday, 1,571 on Wednesday, and 2,380 today. Now, today's higher case count is in part due to a data catch-up process. So that being said, even excluding the cases that are attributed to that catch-up, our total cases for today would be approximately 2,100, a number that we have not seen since the end of January. Our current 7-day average for COVID-19 daily cases is 1,794. This is up from 1,427 last week and 1,252 2 weeks ago. And sadly, we are also reporting an additional 36 deaths since Monday's update. And the 7-day average for deaths has decreased by 2 to 11, down from 13 last week. The number of patients in hospital and in intensive care units has been showing increases, with 894 people currently hospitalized and 332 in ICU. In terms of testing, just over 60,000 tests were processed yesterday, with a positivity rate of 3.8%. Our 7-day average for percent positivity is 4.2%. That's up from 3.3% this time last week and 2.8% 2 weeks ago. There are now 1,563 confirmed cases of variants of concern in Ontario. The majority, 1,458, are the B117 variant originally identified in the UK. 51 are the B1351 variant identified first in South Africa, and 54 are the P1 variant originally identified in Brazil. The 7-day rolling average positivity for the variants of concern is 50.5%, which is up from 43.8% 1 week ago. According to data from Ontario's Science Table, the latest effective reproduction number for these variants of concern is 1.28, as compared to the non-variants of concern with 1.07. I would now like to turn it over to Dr. Allen for her update.
Thank you very much, Dr. Yaffe, and thanks for the opportunity to describe some of the changes that we've made to the screening and testing for variants of concern. So just as an update, the variants of concern have really emerged over the last several months and represent not only mutations in the virus that we were lucky not to have seen in the earlier days, but also that these strains with particular mutations have both clinical and public health significance. We continue to work with our public health partners, and what we have done to date is worked with many partners to develop a robust genomics program with partner labs across the province. We have performed 2-point prevalence studies that have been described before. And on February the 3rd, we implemented widespread testing for a unique mutation that is in the 3 most common variants of concern that Dr. Yaffe has described. The N501Y mutation is in the 3 strains called B117, which was first identified in the UK, the B1351 that was first identified in South Africa, and the P1 that was first associated with Brazil. I think we've learned quite a lot, and Dr. Yaffe has described the rise of the B117 in Ontario, now representing over 50% of our cases. But with this, we have developed new tools to be able to identify with more precision and speed the other 2 main variants of concern, the B1351, first identified in South Africa, and the P1, first associated with Brazil. So as of Monday, March the 22nd, that just passed, a new PCR test was implemented that is performed on PCR positive samples. So these samples are already known to be positive, and it looks for 2 mutations. The original one, which was the N501Y mutation, and a new second mutation called the E484K mutation. This is helpful as the E484K mutation, the new one that was just introduced, is unique to the latter 2 variants of concern, B1351 and P1. This enables much more rapid identification of these variants, and because we know that the N501 mutation found in a strain without this without the E484K mutation is most likely the UK variant or the B117, there is no need to allocate genomic resources to that, as we can get an early signal using the PCR test. So all in all, the change was motivated by getting more rapid results of the variants that are present in Ontario, working with our public health partners to make sure that this informs both the local response and provincial decision making. It does, however, mean that there may be an increase in some of the P1 and the B135, as the goal is to identify these sooner rather than later. With that, I'll pass it back to Dr. Yaffe.
Thanks very much, Dr. Allen. Now, we've been saying this for some time now, but it remains true. As you can see, the trends in Ontario remain concerning. We are in a precarious position. While vaccination efforts are ramping up, just yesterday, over 79,000 doses of vaccine were administered. The province is not yet at a point where vaccination coverage is sufficient to fully prevent the transmission of COVID-19 and its outcomes. And we are seeing this in our latest numbers. Daily cases are increasing, and hospitalizations are increasing, and ICU numbers are increasing. There's no doubt we are in the 3rd wave of this pandemic, and the rates of the variants of concern do continue to rise. So it is important that people remain cautious and vigilant in order to minimize the transmission of COVID-19 and protect themselves and their communities. We need to hold the course and protect ourselves and our communities with our own choices. This is really regardless of what level of the framework your region is in. And it's especially important as dining restrictions have been modified and more outdoor activities are being contemplated. I know that this, once again, will be a disappointment for many, as Passover begins this weekend and Easter is the following week. But we are once again urging everybody to celebrate only with your households and consider hosting virtual celebrations with your friends and family. This is critically important to help stop the spread of the virus and maintain the progress that we have made to date. With that, I'm going to turn it over to the media for questions. Thank you.
We'll go to the phone lines. Just a reminder, 1 question, 1 follow-up. Over to the first question, please.
From Dave Woodard at Global News. Please go ahead.
Good afternoon. Dr. Richardson in Hamilton said the other day that they're not suggesting lockdown just by looking at the numbers, but at the severity of the virus as well as mortality numbers. Is it time the province changes the color-coded system on case numbers alone?
Thank you for the question. The current framework is not based only on numbers. The numbers are part of it, the rate per 100,000, the percentage positivity. It also looks at hospitalizations and deaths and the reproductive number. So I would agree with Dr. Richardson that there are multiple factors that need to be taken into account with the framework, and those are being taken into account as we move on.
Follow-up?
Ontario Soccer sent a letter today asking for, I guess, Dr. Williams to greenlight outdoor soccer for the year, given the fact that it's already late March and registration likely would have started by now. Would you say that outdoor soccer is okay to be doing? And if not, why?
I know that everybody's really itching to get out there and do activities, and we want people to do activities, but we want them to do them safely. And certainly, I know that the Public Health Measures Table has been looking at sports activities and making recommendations, and so these are under active consideration now. But again, I think it will, whatever we are going to be allowing, we'll have to make sure that people are trying to keep their distance and be as safe as possible. So it's under active consideration along with other outdoor activities.
Next question.
From Randy Rath at Stage CHTV. Please go ahead.
Hi, doctors. I'd like to ask you today about migrant farm workers. There are 20,000 of them about to arrive in our province. Last year, we had enormous problems with transmission among the farm workers and out into the community. So much so that there has been a hard cap of 3 people living in a congregate setting. Farmers have been protesting lately, saying that it is unworkable to just have three people living in a congregate setting on a farm, and that this could ultimately affect our food supply. The Chief Medical Officer of Health in Haldeman, Norfolk, has called on the feds to inoculate, to vaccinate farm workers as soon as they get off the airplane. Do you agree with that call? And if the feds are unwilling to do it, should the province be giving vaccine to farm workers as soon as they get off the plane if they want it?
Yes, thank you. I'm very aware of the issues with the temporary farm workers. Actually, we have been working very closely with OMAFRA, who is the lead for it at the provincial level, and with the federal government. In fact, I was on a call earlier today about this, advocating for offering vaccination to the temporary farm workers when they come in, optimally at the airport. So we're working with the federal government on this. Hopefully they will be okay to do it, but I think if they don't do it, we will probably do it because it's important. But there are a lot of considerations, obviously, around not only the logistics, but also the language and making sure that the country they're coming from is aware that we're using proper translation and information so that they are understanding what's happening, that this is a voluntary process, it's with informed consent. But we do think it's an important measure, along with others. Thanks.
Follow-up?
If there was enough vaccination amongst the farm workers, would that eliminate the need for the hard cap of 3 people in a congregate setting? Because we have a lot of, homes that these workers live in that can hold up to a dozen people or even more that are quite large, and they're being completely underutilized with only 3 people in them.
Yeah, vaccine, of course, is a very safe and effective measure. However, if the individual has already been exposed to the infection and is incubating it, the vaccine will not prevent the infection. So what I'm saying is if people are showing up and they're already incubating, the vaccine is too late. So we can't say 100% for sure. If every single person got the vaccine, it would eliminate all infections in these people. It would certainly be very useful and have a very big impact. In terms of I think there's also issues with the transport. We would like people transported in buses where they are cohorted, so the same people are going to the same farm rather than mixing to different farms, which is causing potential issues in multiple farms. The bunkhouses, these are ongoing issues with housing, not unique to temporary farm workers. I am aware of the order that the medical officer in Haldeman, Norfolk did. And I think from a public health infection control point of view, it's important, but on the other hand, it presents many logistical difficulties for the farm, I understand.
Next question.
From Cynthia Melican at City News. Please go ahead.
Hi, doctors. This question is from my colleague, Adrian Gobriel. 10 days ago, the American Medical Journal published a study from the Johns Hopkins University that found the first dose of the COVID vaccine doesn't provide enough protection for transplant recipients, and that they need their booster sooner than the 12 to 16 weeks. And there are other studies suggesting the same thing for cancer patients and those with compromised immune systems. Is the health table going over these studies? Has it? Are you considering making changes to the second dose timeline for this segment of the population? And when might an announcement on this be potentially made?
Thank you for the question. Yes, we're certainly aware of there are certain groups where either there has been some study or some concern expressed around inadequate response from one dose and not waiting for the full 4 months. We have a clinical advisory group that we are working with to look at this and identify if there are any specific groups that should have a shorter interval between the 2 doses. As well, it is my understanding that NACI, the National Advisory Committee on Immunization, is also considering this. So I'm expecting there will be recommendations in the next week or two about specific groups where the dose interval should be shorter.
Follow up.
Thank you. And in watching, it's been over a week or so since the third wave was officially declared by Dr. Williams. And we're not seeing an explosion of growth. We're seeing sort of this steady creep. Do you think that this wave is potentially different? Do you expect it to explode? What are you hearing and seeing?
Well, I mean, it's hard to say, obviously, I can't predict. But the problem is, as we've said, that over 50% now of the cases are variants of concern, predominantly the B117, and we know it's approximately 50% more transmissible, more infectious between people, and the reproductive number is higher. So as they take over to be the predominant strains, the concern is that the infection rate will increase. So which is why we're saying it's so important for everyone to keep at the measures. I mean, I know it's been a long time, people are tired, they're fed up, but I think we can do something to blunt the wave if we just keep at the measures we're doing.
Next question.
From Rob Ferguson at the Toronto Star. Please go ahead.
Hi, Dr. Yaffe. I just wanted to flip back to last Friday's decision on the restaurant patios and that kind of thing. I was out on the weekend and a few days subsequently, and I go to these. I walk past these patios and I see people clearly are not all from one household at the patios. There are clearly people gathering, and now we have the hair salon people and barbershops saying, if people can gather on patios like that, why can they not resume performing haircuts and colorings and all those kinds of things? So could you explain that, please? And do you see a path forward for haircutting in lockdowns?
Well, I think a lot of people are anxious to get their hair done, but I do know that there's been a lot of concern expressed regarding hair salons, barbershops, and it is under active consideration. I think if you're looking at it purely with respect to infection prevention, preventing transmission of COVID-19, obviously we don't want people close to each other. We want people, other than within their household, they shouldn't be within 6 meters. They have to wear a mask, a well-fitting mask. And you can't wear a mask when you're eating, obviously. However, I know that certainly the decision makers have to weigh a lot of factors. And health is not just the physical health illness side, it's also mental health, social health, social well-being, and the economy. So, we give our input as health experts, but the decision makers at the end take in a lot of factors.
Follow up?
Is there more that barbershops and hair salons could do than they've already been doing in terms of capacity limits, the practitioners wearing masks and face shields? Is there more that they could do to make it even safer than it has been under the existing protocols?
I can't speak to the specifics of the hair salons. I know that they did have good protocols in place before. However, it's unavoidable that the people are close to each other. And, hopefully as more and more people get vaccinated, the risk will be reduced. But whatever protocols were in place need to be in place again. And we know that with the variants of concern, the same kind of preventive measures are effective. It's just that they have to be done really, really well.
Last question.
From Laura Stone at the Globe and Mail. Please go ahead.
Hi, doctor. I have a similar question to what Cynthia was asking regarding the length of time between shots. There's a new study out of BC that looked at the antibodies in the blood of long-term care residents who had been vaccinated with Pfizer, and they found it was much weaker than the response in young, healthy healthcare workers. So you talked about reviewing this. Can you just confirm what you're reviewing this for? Is it for elderly people and the immunocompromised? And do you have any further details about the ages of those who would potentially see the time between their doses shortened, and what kinds of immunocompromised conditions? Is it cancer patients, transplant recipients, et cetera? Do you have any more details about what exactly it is you're looking at?
I'm actually personally not on the clinical advisory committee, so I wouldn't know the details, but I will comment that my knowledge is that in British Columbia, they are using the longer time interval between doses for long-term care residents. And we have chosen in Ontario not to do that. We know it's a particularly high-risk group. It tends to be older people who have weaker immune responses. So we have made sure that the residents of long-term care and retirement homes and elder homes are getting the second dose in the recommended time period as per the product monograph. Which groups are being considered by the clinical advisory group and NACI? Again, I'm not on those groups, but I think for the types of groups that I'm aware they're looking at are people with certain solid tumors, transplant patients. But there are many others, I'm sure. I couldn't tell you because I'm not on the groups. We'll have to wait and see what they come up with.
Follow up, and this is the last question.
And I'm just wondering, is the government looking at coming up with new guidance for long-term care homes and retirement homes where most of the residents have been vaccinated, but there's a case maybe brought in by a staff member or something? We're hearing lots of stories about people who are being locked down even though they've had their 2 shots. So what is the government going to change anything here, or are you just going to keep the same policy as long as there's one COVID case in the home, everyone has to stay in their room?
That is an area that I'm working on very actively with the Ministry of Long-Term Care and the Ministry of Seniors and Accessibility, hoping to modify the outbreak definition so that it's more in keeping with what we use in other settings, but yet maintaining, obviously, vigilance. I think what we're seeing now is that it's been over a year. We've achieved what I'm understanding is close to 100% vaccination in the residents. Unfortunately, not as high for the staff, which is an issue. 60 to 70% is what I hear. Pretty high in the essential caregivers. So I think we do need to look at what measures are necessary. How do we balance it with the quality of life? And as somebody said the other day, how do we put the home back in long-term care home? Because this is where people live. And I've certainly heard many complaints, many concerns expressed. We've been vaccinated. What can we do now that's different? And I think they're right, and we are working on how do we modify it.
Thanks, everyone.